waitlisted women to improve the patient journey and timely access to care. Some of those key findings that we particularly wanted to address was the disparity in public gynae services between Ballarat, Horsham, Stawell, and also the difference in access to specialty gynecology care, and the fact that women with non-urgent conditions such as heavy bleeding, pain and incontinence were waiting the longest for care, despite the fact that these symptoms are known to be disabling and can affect quality of life. So as discussed earlier, due to our project timelines, solution design overlapped with our diagnostics phase and occurred in consultation with our stakeholders, taking into consideration the key findings, project objectives, and the collated consumer perspectives. So it was determined a phased approach would support robust implementation. And phase one, which we are in the midst of right now, is focusing on expansion and redesign of existing services and includes implementing a streamed clinic in gynecology outpatients Ballarat, focusing on women with heavy menstrual bleeding to deliver care in accordance with the newly updated Australian Commission of Safety and Quality in Healthcare's heavy menstrual bleeding clinical care standard. It's a bit of a mouthful. Alongside this, we've redesigned some physiotherapy pelvic health clinics, which will be implemented at Stawell and Horsham to better align with services provided in Ballarat. Working groups have been established for each of these areas, and methodologies from implementation science are being used to support the implementation. For example, our heavy menstrual bleeding clinic went live last week, and we used the COMBI framework to support change management required for staff working in the clinic. And phase two will be aiming to try and implement by the end of the year and will follow a similar approach. So while we are up to step 3 at the moment, we are looking forward to step 4, evaluation and monitoring, and step 5, sustainability. We're in the process of developing and implementing an evaluation framework, which will incorporate a family of measures approach inclusive of patient feedback, staff feedback, patient outcomes, and operational measures for ratification by the quality assurance team. And additionally, we are developing a research protocol to analyse the clinical outcomes of the HMB clinic to determine if that care delivery does in fact align with the clinical care standard. And that work is being supported by the Western Alliance Staff Training Program. So that's a quick snapshot of the project. I'm happy to take any questions now.
Thanks, Sophie. Well done. I just sat there and went, oh my goodness, we need you to talk for an hour. There was so much in that.
It felt quite hard to condense down, so sorry for rushing through it.
No, I think you did a fantastic job. There's so many different elements to that. Well done. Questions from the floor? Not putting you on the spot, Anna, but you've got your camera on, so I assume that's because you're going to ask a question. Thanks, Anna.
Yep. And I missed just the beginning of that, Sophie, so apologies, but sounds like there's a mountain of work that you've already done in a short time frame, so well done. And just great that it sounds like you're using a range of different processes to get the work in place, and that you're a star participant, so fantastic, and that's driving some of the research, so really excited about that.
That's it.
So how long does the project go for altogether?
So at this stage, we'll be finishing up in February. So that's why we're sort of shifting focus to making sure that we're getting evaluation frameworks embedded into, I guess, kind of business as usual approaches. So really trying to get to that point as quickly as we can. Yeah,
okay. All right. And then in terms of, it's always hard with these projects when they're short term. Do you know what the plans are with Grampians Health after the project finishes in terms of being able to do some of that evaluation and look at the sustainability?
I'm not sure if Catherine wants to jump in or not, but I think what I'm trying to do is, I guess, make sure that the little initiatives that have fallen under this umbrella are in a place to kind of carry on with that work, depending on how far we get into those steps. Yeah.
We're hoping that obviously the clinics are business as usual, but we also have some scope in there to looking at future plans of how we could streamline some of the gynae services, and this is obviously, trying to enable that to happen with the heavy bleeding stream of care. But also I know that Sophie's done some work in and around how we could look at advanced practice for physiotherapy in the space of pelvic health and care, and these clinics are kind of trying to put a structure in place for those sorts of things to happen.
Yep. Okay, fantastic.
Yep.
Yeah, well done, you guys. Great job.
Thank you.
And one question just that's come in, oh sorry, two incoming from the chat. So just from Katrina, did you collaborate with the Tell Your Story reporting from Women's Health Grampians?
Sorry, I did just see that there. We are engaged with Women's Health Grampians, so we're on a sort of a regional steering committee because of the overlapping aims of kind of both of these elements, but didn't specifically work on the Tell Your Story, but certainly those results are helping inform some of the work that we're doing in the project.
Great. And one last one just from Denise. So was stall included in this project? I understand that the Northern Grampians Community Care Centre employs a GH nurse privately to work in their clinic.
So stall is, I guess, part of the scope of the project. I don't know if I'm specifically aware of that nurse, but yes, we are implementing initiatives. So one of the things that we're working on at the moment is the physiotherapy pelvic health clinic, which will be implemented at stall hopefully within the next few weeks.
Okay, great. Denise, did you want to add to that? Or sorry, I noticed you've just come on camera.
Not really, other than that, yeah, one of our educators in one of the nurse educators has some experience and qualifications in women's nursing.
We are
so
engaged with that. Yes, yeah. So yeah, I know who you're talking about now. Sorry.
Katie would be
yes.
loving this, I can imagine. So
yes,
I thought you
we've had some good
in.
catch-ups with Katie. And I guess one thing that we didn't cover in this is, but an aligned piece of work that's kind of under this umbrella is Sexual and Reproductive Health Hub, which felt like too much to put in this, but that's also a piece of work we're doing in the project as well.
Great work, Sophie. Well done.
Thanks.
Yes, well done. I agree. Well done. That's fantastic. Very good. We'll move on to our second presentation team now today. So we've got Jeevan, Bhusal and Nalaka, Kolamunna. And their project is Medication Adherence Amongst People with Schizophrenia, a qualitative study to explore the barriers in a regional mental health service. And Jeevan too is a Western Alliance staff participant, which is great to see. So thanks, Jeevan. Waiting for the slides to come up. That's sharing, but it's in presenter view.
Can you hear us?
Yep, we can hear you. And your slides are sharing. It's in presenter view, which is fine, but just if you're able to share the other window.
How does it work?
Yeah, if you click on display settings up there in the middle on the top bar, click on that display settings.
Just give it display. We're sharing the slides and we're going to
go back. That's it. Yep.
That's it. Okay. So you can do it.
Yeah. You can see the slides, right?
Yes.
We can see the slides, right?
Yeah.
Yes. No, we can. Yep.
Yeah. So thank you very much, everyone, for joining us today, and thanks, Ash, for having us, giving this opportunity to present a small study which was done by Grampians South community team in Ballarat. So we have a few people who participated in this small research project, which was a qualitative study. And Jeevan, who is working as a treating clinician, his background is social work, so he was the team leader of the research project, and I'm presenting as the psychiatrist for the team. So I will start the presentation, and then during question time you can ask questions, and Jeevan will be the one to answer the questions. So I acknowledge the traditional owners of the land before we start the presentation. Ash already did that. The next slide, let's go to. So bit of background. So in terms of us, our job in mental health, we have maybe 30%, 40% of patients with schizophrenia in our caseload. And as you know, the schizophrenia has a global prevalence of 1 in every 222 individuals. So it has a huge impact on the population. It's estimated 150,000 to 200,000 people, and it is the third leading cause of disability among mental and substance use disorders. So as of June 2023, the India has reported schizophrenia as the fourth most common cause of disability. Out of 610,000 odd active NDIS participants, half of these participants, 50.9 to be exact, had diagnosis of schizophrenia. And the main problem with our client load is that when the clients are not compliant or not adherent to medications, it can lead to poor outcomes in their illness trajectory with regards to repeated hospitalizations, poor functional outcomes. And so the patient, the adherence to medication is a major clinical problem in supporting patients, clients with schizophrenia. So in terms of Ballarat, we have about 340 case managed patients linked with adult acute community mental health team as far as July 2024. And 24% of patients out of our caseload are on long-acting injectable medications because just to overcome the poor adherence to the oral medications. So just to continue the background, so as we have previously discussed, the individuals with non-adherence to medication, they are 5 times more likely to relapse and 12.5 times more likely to do complete suicide. So that's the really bad outcome to have. So in terms of the research gap, there is a need for more localized qualitative research in Australia on schizophrenia and medication adherence, as the existing studies largely come from other countries with different sociocultural contexts, limiting the applicability to the Australian and especially the regional Ballarat context.
And I think we also believe that the causes of non-adherence depends on the socio-economic, political, cultural aspects of different societies, and it varies from society to society as well.
So the objectives were to explore the barriers individuals have with schizophrenia whilst they are taking their medication, and what are the challenges in adhering to prescribed antipsychotic medications. So the methodology we used was so we initially about the ethical considerations. So we were able to get ethical considerations as per the protocol, and a little bit about inclusion and exclusion criteria. So we did the project on the clients who are aged between 20 and 65 years. So they are the ones who are attending the community clinic, has a diagnosis of schizophrenia, the medication adherence history and the treatment history. They have been on medication for at least 1 year, recorded the history of medication non-adherence, and also they are receiving depot injections. And
I think so people who were on LAI or depot injections, they were automatically eligible, and people who had a history of involuntary treatment without having 24/7 residential support in place were also included, and the participants needed to be currently case managed by Grampians Health area mental health and wellbeing services and living within the catchment of Grampians Health Ballarat. And people with lower than 21 mini mental state examination score were excluded, and consistently impaired cognitions and poor insight or poor judgment for the past 2 months were also excluded. And patients who had no non-adherence documented records or incidents were also excluded. And this is we consulted with our psychiatrist and the medical staff about their decision-making capacity, and we also assessed periodically. And if they didn't satisfy the decision-making capacity, they were also excluded. And people with a diagnosed conditions of ABI, intellectual disability, or other neurological impairments disabling their informed decision-making capacity were also excluded from this study. And participants, we offered training and orientation to our mental health clinicians about the project frequently. And we also obtain verbal consent. The clinicians or the referrer obtain verbal consent from clients before they refer them to the research team. And they also provided detailed study information before the participants were referred to us. And we assessed their suitability periodically and frequently. And we also consulted with the respective consultant psychiatrist or treating psychiatrist regarding their eligibility. And then we had direct contact and we discussed with the participants and we provided them participant information and consent form and offered them 2 weeks to consider whether they want to participate or not. And they could withdraw at any time without any consequences. And we also focused on participants' well-being with an option for allied health services referral in place because we were dealing with the most vulnerable people living in the society. And now, Dr. you can present.
Yeah, so the data collection, we conducted semi-structured interviews, duration lasting for 1 hour. We conducted interviews at Queen Victoria Building, which is the site for the patients attending the regular reviews and depot injections. And we also conducted some reviews in residence and community centers. So in terms of the questionnaire themes, so the interview was focused on the client's experience of taking prescribed medications, motivation to take medications, challenges they have faced in terms of taking medications, and their perception of advantages and disadvantages of taking medication.
So we employed Brown and Clark's reflective thematic analysis approach to understand the medication administration experience of participants because of its flexibility and opportunity for the reflexive influence of our interpretations as a researcher. And it has got like 6 different stages from familiarizing of data to interpretation of interpretation and production of the report. And these are the characteristics of our results. So we interviewed 6 participants, 5 male and 6 female, and their average age was 43, with variance of 13 years, and median age was 45 years, and average age of illness onset was 12 years, with a variance of 7 years. And 10 participants had completed secondary school, and 4 of the 11 had completed university degree as well. So, all participants had at least one history of inpatient admission experience, and 4 participants had a history of homelessness, and 5 of them had history or active use of alcohol and other drugs. And 1 participant was living with family, and 5 of them was living in a private rental property, whereas 6 participants were living in a supported or social or public housing in the community. And our finding was we found 11 common themes or challenges that they had experienced when it comes to taking medications, and that influenced their likelihood to comply with the prescribed medications. And forgetfulness was a common one, often forgetting to take medications, and alcohol and other drugs use was another one, because they were under the influence of alcohol and other drugs, and often that leading to other causes. And therapeutic relationship with treating team was the another problems that they had experienced, and unwanted or adverse side effects from prescribed medications was another challenge that they, for example, feeling of drowsiness, weight gain, and similar other side effects also contributed to non-adherence. And one of the unique challenges to Ballarat region was transportation and loneliness. People reported feeling lonely and socially isolated, and that leading to stress, anxiety, and not wanting to take medications, feeling of hopelessness and helplessness. And transportation was, they reported adverse weather, and sometimes it's raining, windy, and long waiting time for public transportation. And often if they miss the bus, needing to wait for like an hour or more to get another bus, and not having enough financial resources to be able to afford a cab or other transportation services. And inadequate support and loneliness was also unique to Ballarat. People were socially isolated, often estranged from their family members, not having enough social circle around them to provide informal, emotional, and therapeutic support in place. And some people had indifferent values, and they prioritized other things than medications. For example, some of them prioritized drugs to take alcohol, or spend their money for methamphetamine, cannabis, instead of taking medications. And some of them prioritized herbals, medications, and alternative treatment instead of pharmaceutical treatment. And another interesting thing we noticed was some of our participants selling their medications such as quetiapine, Valium, to make extra money, and because of the street value, and they were not taking it. They were accepting the medications but not administering it, instead providing it to their friends or other people on the street, often selling it in some money for their pocket expenses. And homelessness and housing was another issue. As I mentioned earlier, 4 of them had experience of homelessness, and while living in the street, not having enough support, not having money, and not having access to their medications. And command hallucinations was another thing. Some of them reported that the voices instructing them not to take the medications, and some were under impression that voices were advising them that we were against them, and we wanted them to feel bad and affect their quality of life, and that's why they were not complying with their medications. And another one was poor insight, not understanding the value of medications, and often experiencing relapses and rehospitalization. And we've got a couple of recommendations based on the literature we found. And interestingly, we found like 21 qualitative studies on schizophrenia, interviewing patients to understand their experiences. Out of them, only 14 were related to our topic, and only 1 study from Adelaide was on the same topic, and which was done in the metropolitan region, and reflecting the research gap. So our recommendations are to enhance access to telehealth and home services. Local mental health services, we think, can offer telehealth, home visits, and home delivery to improve access and efficiency for patients. And psychosocial support, clinicians should provide psychosocial support to help patients manage antipsychotic medications and side effects. For example, healthy lifestyles, involvement of dietetics, and promoting healthy lifestyles, early connections with peer support, early use of long-acting injectables, shared decision-making, and family inclusive. Right?
Continue. We'll finish quickly so that
social prescribing. I think we also recommend social prescribing for non-medical support. We believe that social prescribing can help to connect patients with community resources and support networks, improving overall well-being, resilience, and independence as well. And another one was cultural competency training to mental health professionals by offering regular or annual or periodic cultural competency workshops for mental health practitioners to deepen the understanding of the community cultural dynamics can also contribute to better and therapeutic rapport with the patients. And conclusion was, it was our first qualitative study in Ballarat and in entire regional Australia, because to the best of our knowledge, we didn't find any qualitative study on this topic in regional Australia. There was only one in metropolitan Adelaide. And transportation issues, social isolation, financial hardships, and housing-related problems uniquely contributed to non-adherence in Ballarat. And key obstacles were unwanted side effects, illicit substance use, poor therapeutic alliance with treating team, forgetfulness, poor insight, and individual choices. And recommendations are to promotions of social prescribing strategies, telehealth and home services, improving public transport in Ballarat, shared decision-making in treatment, improvement in cultural competence of clinicians, and demotion of authoritarian prescribing. These are our references. If you've got any questions, please feel free to.
Thank you very much for listening to us.
Thank you. Well done. That was great. Are there questions from the floor? While people are thinking, I actually have a couple. I was just you mentioned in the earlier slide, I think it was the poor compliance rate of around 24%. I was just wondering, did you look at, is that consistent with other regions, or is there sort of benchmarking or data around that at a national, state, regional level?
There has been a couple of studies in Africa and not in Australia. And I think, as we mentioned earlier, socioeconomic and political state of
but the people who are on depot or long-acting injectable medications, we don't usually take it as the KPI. We usually kind of get KPIs in terms of how many percentage of patients who are on community treatment orders, but we don't usually take the patients who are on depots or long-acting injectable medications as a KPI.
Thanks. And John, you can see your hand up.
Hi, thanks. I just want to ask about, because I'm in the ethics office and saw all the work that went into this project before recruitment started. And you see the slide about the participant consent, and a very rigorous consent process was developed, informed consent, and you still had good recruitment out of that. I think sometimes because of that very respectful process. My question is just, when you actually come face to face with participants and conducting the interviews, how was the research received by them and this chance to have an interview?
Yeah, so first I'll go first, John. So as you said, we had some difficulty in recruiting participants for this project. So, but it took a while for us to recruit 10 clients from our community, the mental health, the client cohort. Do you want to comment on?
Yeah, I think as planned in our protocol, we interviewed participants in their home and community center.
How did they receive the interview?
I think they reported, some of the participants reported feeling empowered, and they said nobody had asked them such questions before. And they were so happy and very recommending other people as well. And whereas other people were, as soon as we mentioned schizophrenia, they were like, no, I don't want to participate in this engagement. And they thought that we're gonna, document it and it will affect their future life. But most of the participants felt really empowered, and they clearly mentioned that they were happy to talk about their experiences because nobody had asked those questions to them in the past. And they were appreciative and pretty forthcoming with information, needing pretty minimal prompts and.
Yeah, and that reflects the research gap that you found. This cohort has not been engaged this way before. And I just wanted to note, if people know that Grampians Health have the welcome days in January or February at each campus, and the library sets up a stall, research sets up a stall, and Jeevan actually came to us less than 2 years ago, not having done a lot of research before, a little bit, but saying that he was new at Grampians Health and wanted to do a research project. Less than 2 years, here we are. He's presenting. He's a Western Star grant recipient and participant, and bringing social work perspective to the mental health team doing a research project. And here we have research participants feeling empowered and some really good data that will certainly find publication somewhere. So well done, Jeevan.
Yeah. He has set a precedence to our Grampians mental health to do more research. Yeah, in the
fantastic.
ground.
Fantastic.
Fantastic. We've just got one question here from the Horsham team.
Hi, I'm Michelle. I'm one of the librarians at Grampians Health. This is a really fascinating subject. I've got lived experience of family history with mental health, and I'm really interested in this. My question is, has there been any discussion or planning to do a post-research follow-up with either existing participants in, say, 3 to 5 years, or maybe redoing this research with a new cohort in a period of time to see if the results can replicate or if they are actually sound through replication?
Yeah, thanks for that question. So we are planning to recruit, because I don't think we recruited any plans from Ararat or Horsham. So that's probably a gap as well. So we are planning to expand the study in the months, coming months, to include more participants actually, and see whether the findings are replicable. Yeah.
And I think in the beginning, we wanted to include, our initial idea was to include Horsham and Ararat and cover entire catchment area of Grampians Health. However, we didn't have resources, and we had almost no resources to begin with. And now we've got some funding, but we're going to produce report from Ballarat region, and we can expand in the future as Dr. Nalaka advised.
It's important work. Well done.
Thank you.
Thank you. Yeah, well done. That was fantastic. Thanks, team. So we'll move on to our final presentation for today. So we've got Darlene, Cole and Sammy Russell. Yep. Oh, just checking both there. Perfect. Well done. So looking at the application of a clinical confidence scale in understanding the capabilities of the current mental health and wellbeing workforce. Yep, and that's sharing. Thank you. Just on mute, Sammy, though.
Yeah. Okay, now you can hear us, but you can't see the slides. So give me one more second.
No worries, that's fine.
All right, nope. I've got to get that.
Yep.
Minimize there.
Yep, that's perfect.
Just minimize that one. Yeah. But hang on, they're still on the screen.
We can see your slides, okay?
Yeah, it's all good?
Yep.
All right, perfect.
Okay. Thanks everyone for having us. My name's Darlene Cole. I'm the social work lead for mental health and wellbeing services, and Dr. Sammy Russell's our mental health research officer. Thanks for having us today. This is a piloted quality project. Just wanted to preface that. So while we're sorting ourselves out.
Down.
Can you put your mouse there? Yeah,
There we go.
great. So our Workforce, Our Future is a capability framework for the mental health and wellbeing workforce. It was developed by the State of Victoria Department of Health in response to recommendations from the Royal Commission into Victoria's mental health system. Released in September 2023, the framework provides a foundational tool to which services were invited to build upon toward ensuring the workforce has the right capabilities, size and diversity. The framework's also designed to support and develop an appropriately skilled, competent and confident mental health workforce. And we aim to develop a survey to capture clinicians' confidence relating to each of the 15 capabilities to inform the education calendar for 2025. So we created a clinical confidence survey adapted from the EPIC survey to fit the capabilities framework. We designed it to be anonymous. It asked one question about which age stream the clinicians worked with, followed by 18 questions related to the capabilities. We asked clinicians to rate their confidence between 0 to 100% for each question. So those 18 questions are listed on that slide.
So for our methods, we piloted 3 surveys and we got feedback from each of these pilots. Some of the feedback was to change the legislation question to split it into 2, focusing on the mental health legislation. We also added a medication scope question. We added the age stream question, and we also formatted the survey itself so it was easier to use. For the participants' recruitment, it was conducted during regular team meetings, through email invitations, and through the help of the clinical nurse educators' encouragement.
So this graph displays the total survey scores from all participant responses. We received great response with 174 surveys back. The bottom axis represents each of the 18 questions and the side axis represents confidence levels in percentages from, it says 0 to 10, but they're 0 to 100. So you can see there that lowest confidence reported in legislation, or the legislation question, First Nations, family violence, system linkages and substance use, and the highest confidence in compassionate care, holistic assessment, medication scope, families and carers, and crisis work.
So we decided to dig a little deeper into our results because we wanted to explore some of the comparisons. So here we have those responses which have come from community-based settings versus bed-based settings. We conducted a statistical analysis which resulted in 6 statistically significant differences between these groups displayed here with the red stars. So self-reported confidence levels in questions relating to suicidality, family violence, family and carers, compassion, navigating systems and linkages are statistically significantly higher in those who work in the community setting compared to those who work in bed-based units, with a p-value smaller than 0.05. So we aim to repeat this survey yearly with the next collection starting in June 2025. And we also aim to put in a proposal with the ethics team to get this into a research publication and make it officially not a pilot. And thank you for listening.
Thank you. Well done. That was a fantastic rapid fire presentation. It's quite difficult, isn't it, to get it down into 5 minutes. So congratulations on that. Can I just, questions from the floor, obviously, but can I ask in terms of the size of the workforce? So you mentioned the 174 responses. Do you have I guess, one, do we have a an accurate awareness of how big our mental health workforce
Yeah,
is.
so our Director of Nursing often quotes this as about 440 staff. It's somewhere in between the 440 and 500, depending on who you talk to and sort of EFT percentages.
So that is really quite a very high response rate, isn't it? Was there consideration around collecting some of the workforce, not necessarily demographics? So you obviously had bed-based or community, you stratified, but did you have other?
Yeah. So
one of other slicing and dicing of the workforce?
Yeah, one of the other, we mentioned sort of at the front end that our workforce, aside the bed-based and community settings, is when we think about the Royal Commission recommendations, really looks at things as in the teams that work with people aged 0 to 25 and 26 plus. Or our adult and older communities. So we did ask, that was one of the adjustments to our to our survey for the final run. And I can't remember if there were other.
It was the only question, we asked was the age stream, and we were able to do the comparison results between bed-based and community because we physically went out and handed out the surveys to everybody, and we put a collection box, and the collection box had the label on it that this is bed-based, this is community. So when I got the responses back, I was able to determine this group were from here, this group were from there. So that wasn't necessarily a question asked in the survey, but it was within our collection. We were able to get some of the results from there.
And we were really conscious just about the anonymous nature of the survey, or wanting to keep it anonymous at this level, because I guess there's a lot of work that's being done, or, surveys often get put out to staff, and we understand that staff often are concerned about how they'll be judged, and we really promoted this actively as this will contribute to the learning and development calendar for next year. So we just wanted those broader voices being spoken to.
Yeah, absolutely. Fantastic. Well done. Anna?
Hey, fantastic job, Sammy and Darlene. And this isn't, like, obviously the findings are great and going to be super useful. I know you're going to put them into practice to inform the education, and you're going to monitor that. Just interested in how the process has been. Working together on this, you've done quite a lot in a short time. Yeah, I'm just kind of interested to hear.
Did you want to respond to that?
Doing this has actually introduced me to lots and lots of people that I would not have met otherwise. Handing out the survey, sitting on meetings, introducing myself and saying, please do our survey, put it in the pink box, because we created pink boxes to collect this. This has been a bit of an inside joke. We've got these boxes everywhere. It's been really good because I've got to meet so many different teams that I didn't even really know were around, being new at Grampians Health. And getting the response we've got was huge. I honestly was not expecting, this many, 174, I think it was. It was massive. I was thinking maybe 30 or 40. And this was they're all in-person responses as well. So that was really fantastic to actually connect with people and have them be like, yeah, you know what, like I will do this survey. Why not? Just, 2 or 3 minutes, chuck in the pink box. So yeah, it was good. I got to meet a lot of people.
And I guess from my perspective, there's a few levels and layers to this. One being it was a great opportunity for me to really get my head around the capability framework and really unpack the Royal Commission recommendations and start to promote that in a more active way. And also a part of the reason I do the role that I do is to hear the clinician voice and really promoting that. And, how can we support you? And the other part of this is for research, and it's just been fantastic to have Sammy as part of the mental health service as well, and starting to, I guess there's that education around what research offers, or what our evidence can, offer to us, understanding how we continuously improve. And I think it's, I guess it's testament to Sammy that we're seeing a number of, or certainly a percentage rise in clinical staff that are starting to develop an interest in research and really starting to contribute more as well.
Yeah, fantastic. And so, Sammy will have to pay you later for that, obviously. Hey, and I just want to say what a great job you two have both done working together. And, you know, it's a credit to the team, and Darlene's really helping bed Sammy and the team and, you know, make her feel welcome and really linked her in with people. But I love the way that, like, you did all those pilot testing. You did it all rapidly. It wasn't a big, you know, carry on. It didn't take ages. You tested the tool. You got it out there. Credit to being on the ground, because that is huge, and getting such a, you know, that's why you got such a good survey response, because you were out there and you were being seen. So well done to both of you.
Thanks, Anna.
Thanks.
Yeah, well said, Anna. Very good. Are there any final questions from participants online? Hands up. Okay. You're off the hook, Sammy and Darlene. So thank you again. That was great. And thanks again, everyone, for joining us. We're giving everyone a few minutes back in their day, which is always a nice thing. And just a reminder that we've got one more online session next Thursday, so same time. So bring your lunch and join us for the final session. Thanks, everyone, for joining today, and well done.